I know this thing is on, and I know that you can hear me. Nursing and healthcare needs advocates and activism. So what are you waiting for? Let's do the damn thing. Have you ever had to sit on a stand and testify about how your practice was? Did you ensure that you documented to remember what you did 8 years ago or, in labor and delivery up to 21 years ago? Well, it might be a good time to strengthen your practice and maybe understand what the other side of the house looks like, particularly from nurses who do this type of work. Have you heard of the role of a legal nurse consultant and what they actually do and how that might be different from a quality improvement specialist? Today, we're pulling back the curtain on the side of this profession, which is often whispered about in break rooms, but rarely understood, the world of legal nurse consulting. As the healthcare landscape becomes increasingly complex, navigating a post-pandemic reality, the rapid fire integration of AI, and the growing demand for systemic accountability, the role of the nurse has never been more scrutinized. Should be scrutinized. But who's in the room when the legal definitions of care and negligence are being written? Has your practice met the standard of care? Joining me today is someone who has lived every facet of this evolution, from the bedside to the bar, to the invisible legal risks facing nurses in 2026, and how nurses can leverage their expertise to ensure the system, not just the individual, is held accountable. Welcome, Dr. Nwsou, to the show. So, welcome, Cambria, to the Greeners podcast. I'm so glad that you could be here with me to have this conversation. Of course, there were some delays, but we're here today, which is what matters. And of course, with any of my guests, I always like people to start off with a little bit of their background, telling us who they are. Because I know you're very popular on social media, but maybe some of my folks don't know a little bit about your background. So maybe just start with who you are, what you do, maybe how you got into nursing first, and then how you landed into the work that you're doing today.
Okay, awesome. Well, for those listening and watching, I'm Cambria NWOSU. So I am a registered nurse. I'm a legal nurse consultant. So for those who haven't heard of what that means in the United States specifically during malpractice cases, I work in between healthcare and the legal system. So my job as a legal nurse consultant, I translate medical records because that is the sole source of evidence in cases like that. We translate those medical records into legal context. So objectively, I look at a medical record, give a chronological account of what happened during that patient's care, regardless of sides, regardless of what people think happened. And then I review and identify if the standard of care was met. So I help attorneys and law firms understand what actually happened from a clinical perspective, and then it's their decision on either informing their clients whether the case has merit or it doesn't. And so I work a lot of times behind the scenes outside of social media that people may know me from, but I do work with multiple clients nationwide on just various types of medical malpractice cases. So that's like my niche in nursing right now that I do work in. Before that, I started as a nurse, as a perioperative nurse. So I was in the operating room as a scrub nurse and a circulating nurse. That's how I started straight out of nursing. So I actually graduated nursing school, did an externship while I was in my last semester of nursing school. And the externship was in the operating room.
All right.
Right. So as a result of that, it was like an 8-week externship. Just me learning in those quick 8 weeks, the operating room was like, yeah, we want her. So they actually recruited me from nursing school. They said, hey, we'll give you a few months to take your boards, pass it. So at least you'll be in training mode. And then from there, I did a whole year of training, which is very rare now. We did a whole year of clinical orientation, and I went straight into the operating room and started learning all the specialties. So a very non-traditional path. Most nurses either go into med surg or tele or the ER first, but I went straight into the operating room and then kind of worked my way backwards. So from there, moved on into management and leadership. So kind of worked from the bedside into operational leadership, started running stroke programs, worked a lot with neurosurgery as a nurse navigator. So I actually educated patients on what surgery was like, what to expect, how the post-op recovery would look like. And then from there, Actually, which was interesting, while I was running stroke programs, I was recruited by a telemedicine company, a national telemedicine company, to run their neurology program, which I've
Okay.
never done. Yeah, I've never done telemedicine in my life. I said, I don't know anything about it. They're like, no, 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 we need a nurse expert to rein these doctors in, as well as and also help bridge these relationships with the hospital clients. So
Right.
that was me now working on a hospital systems level, creating those type of relationships. So that happened in 2020, right when COVID hit the United States. So it was
Mm.
just the timing was very peculiar, but it happened right then and there. So I transitioned out of the hospital setting into more of the telemedicine space and then worked there for quite a few years. But in between then, myself and my husband, we were building our own non-attorney legal practice. So it's called Sun Inc. And he's a paralegal. So he was always working with hospitals and clients and law firms anyway to help them prepare cases. But
Right.
which was interesting, my nursing school clinical instructor, who she's a mentor to me to this day. She's a legal nurse consultant. And she said, Cambria, you would actually love this. Let me talk to you a little bit about what legal nurse consulting is. I never heard of it, didn't think about it ever. And she's the one alongside my husband. They were like, yeah, I think because the way your brain works and you like to think critically, you like to like read in between the lines, I think this would be for you. And that's kind of how I got into it. So yeah, it's interesting. It's been, wow, I've been a nurse going on 16 years now. So it's been 16 years. And it's interesting because, as we all know, you're a nurse, but you can do almost anything. It's like there's
Right.
so many pathways to go. And so it's kind of interesting how I started at the bedside, kind of moved up into seeing like how systems work, how operations work, how I didn't like how a lot of things were operating. So that's a whole nother story. But then also looking at from a legal standpoint. And I'm fascinating with that piece because now I can actually work with advocacy and policy. And so for those who know me on social media, that's kind of like where I rein in that type of dialogue and expertise because I found that there are holes in information, not just the misinformation that we're seeing, but it's more so just lack of knowledge, not from our own patients ourselves, but even our clinicians. Because
Mm.
when you're working as a clinician, you're kind of like siloed and you're kind of in this bubble and not really seeing the full picture of how a policy decision now hits a healthcare system, that hits a hospital, that now hits the clinicians, which hits the patient. Like there's a whole
Right.
cascading effect that people are just unaware of. And for me, that was fascinating. And it's interesting how that kind of parlayed into my social media presence, where I feel it's important as nurses, especially now, to advocate and to educate
Yeah.
and also call things what they are. And I think people like my bluntness on certain topics. I think this is where we need to have that conversation about advocacy and healthcare policy and how that, and that's kind of like what drove my social media presence. I just felt that the education was absolutely necessary and needed there. So, but outside of all that, yes, I'm a wife, a mom, I'm a fully fleshed human being as well. And I think people tend to forget that, oh, we're just nurses. But I felt that it's important for people to also recognize that nurses are experts in their field. I think
Yes.
we tend to always rely on our physician colleagues, which is completely great. But there's a lot of conversations and decisions that are happening that do not include nurses that should. I mean, there are the major stakeholders and a lot of policy decisions and a lot of things that are happening. And I feel that if I can help with my voice, then I did my job. So, but yeah, but that's basically how I got into nursing. It's just been a parlaying of one thing after another after another.
No, I mean, I think that's exactly why I started this podcast too, right? I think that we limit ourselves. Yes, we are whole people, but when speaking to nursing as a profession, like I don't think people realize how much knowledge we actually do have. And all of the various different aspects and places that we can work to, really bring our skills and knowledge to different areas. I think you're actually my first legal nurse consultant
Hey,
that's come on the show. Yeah, I look at you. And it's such an interesting position to me because when I think about like we must have legal nurse consultants here in Canada. I'm not too sure what their names are. Quality review is very different. So hospitals have their own internal processes where they do, I guess it would be, let's say, similar to this work where they will do a chart review.
Correct.
But again, it's non-punitive, right? So they're not looking at from that legal lens where you're looking to see if there's harm and that if there's something that can be done out of it from that standpoint. So I worked in quality, and our whole thing was like just culture. But I kind of struggled with it because, you know, at the end of the day, yes, it's so important that we have people that'll come to the table to say, here's what happened in this clinical situation. They feel that they're in a safe space. But I feel what trips people up is the fact that if there was harm and it was egregious, that the hospital system really kind of puts their hands up and says, well, it's up to the family as to what they want to do. And I'm kind of like, really? Okay, fine. Fine. We'll play that game. But again, I think the fact of the matter is nurses should know that there's so many different aspects. And I really love this idea behind legal nurse consulting. And I mean, I listen out for your videos. So I'm like, I'm going to learn something.
Yeah.
I'm going to learn something today. And I think that it's good for not just, you know, regular folks. It's good for nurses too, to be able to see and learn about all these different aspects and how, you know, the legal side really plays into it.
Absolutely.
And I like the fact that you talked about the intersection of politics. We can probably have a whole other episode just talking about how healthcare, nursing, and politics intersect and how the different things that are created, the policies and procedures that are created, how they can create, you know, inequities or harm. And I think that any nurse, and again, I'm going to say this time and time again, and nurses can be mad about it. It's fine. Healthcare is political. And if you don't understand that, then I mean, I think you need to take a front seat lesson. It's a Dr. Cambria's class to learn how healthcare is political. I was just wondering, as you were telling me your story about like how you pivoted and kind of went into this, was there any aha moment or pivot point that you're like, yeah, this is what I need to do?
As far as legal nurse consulting in itself, or
Yeah.
okay.
Yeah, because it was kind of like, hey, once you come, you'd be really good at this. Try this. Because you could have always been like, oh, no, this is not for me. I'm staying with you know, telemedicine. But what was the thing that was like, yeah, I'm going to stay here?
Yeah, I think, well, it's interesting because I was doing both at the same time. So, like, I was
Okay.
learning how to be a legal nurse consultant because you just can't just dive into it. You actually have to take
Right.
classes and actually learn legal jargon and learn what torts is and causation. Like, you have to actually understand what lawyers are looking for as opposed
Right.
to what we think they should know. So there's actually like classes that I actually had to take. So while I was like learning the nuance of legal nurse consultant and also the business side of it, because that's a part that people don't really understand. They just think, oh, it's a job. I would say 80% of legal nurse consultants are independent contractors. You're running your own business. So you actually have to learn that side of it too. So I was literally doing telemedicine and that at the same time. So I think in the process of me learning cases and actually doing practice cases and also shadowing a couple of legal nurse consultants and seeing what they saw, there was a particular case, not to get super specific, but the patient was extremely young and they ended up, you know, passing away. And there was just a lot of, we didn't see that there was actual like standards of care breached, but because certain documentation just wasn't there. I mean, again, you're talking about a jury pool and you're talking about judges that don't know the medical system. They're literally, all they see is black and white. Was it in the chart? Even if it was in the chart, how specific was it? And so like
Right.
just that particular case like was an aha for me to say, wow, something as simple as not documenting could now be a malpractice suit that could cost someone their job, their livelihood, a patient their life. So like stuff like that really, I think it was more so the behind the scenes of me learning how the intricacies of how cases unfold and the fact that nurses are a big part of it. Like, yes, there's, and that's, and there, and then I learned there's two specific sides. People get misunderstood what there's expert witnesses on cases, and then there's legal nurse consultants. And expert witnesses can be nurses as well, depending on if it's a case involving nurses. But those are two separate realms. And so for expert nurses, you definitely would have to be in your field. So like if it's a case about pediatrics, you need to be board
Right.
certified in pediatrics and actually still practicing in that field to expertly testify to that case. So that's completely different than just, reviewing medical records and advising as a consultant to an attorney. So like those type of nuances I had to learn early on. And I learned early on I do not like being on the stand. As much as I talk and I'm just that's just not my jam. Like I rather sit and
Right.
witness something rather than being on the stand, being like grilled by attorneys. That's just not my thing. So yeah, so I think that was kind of like the biggest piece for me learning behind the scenes and then working at the same time. I said, yeah, I think I want to do this full time. I was like, I think this is because I mean the volume's there. It's just and then also a big piece of it is the relationship building. Again, some attorneys, and depending on the state you're in and the jurisdiction, some attorneys in law firms, they don't see the value in what we do. They're like, well, I've been winning these cases. And it's like, that's nice and all, but, you could have probably won more depending on certain things that you may have missed. So it's like
Right.
a lot of it is also proving yourself to these attorneys and law firms that why are you valuable? And so that's a big
Right.
piece of it too.
I mean, if there's one thing that nurses can take away from this, and I think this was one of the first things that I was taught, and I think it still rings true to this day. And again, it came up in this conversation. If you didn't document, it didn't happen. And it's just time and time again, like documentation's this. I remember, so I worked in labor and delivery, so highest place for
Yes,
litigation. I'm assuming it's probably the same in the US
yes,
as well. And it was just have up to there was like really no I shouldn't say statute of limitation, but essentially it was like they have up until like their 21st birthday
mhm,
to bring lawsuits in. So if you can't remember what you charted 8 years
correct,
ago, or your charting isn't so crystal clear that when you go back into the EMR or your paper records, that it is like a full-fledged story,
right.
then you're cooked. Like you are cooked. And I remember being pulled into a case and I was a new grad. So I was just like, was already on the ball. And I knew because I was in labor and delivery that, your charting is word, it's law. And I charted like I remember pulling up this chart, the lawyer gave it to me and I was like, this is good. I was so proud of myself. But the thing is, it's so important that whatever you put down, whatever happens, it's so important that your documentation is sound, it's clear, is up to date. Late entries, I could tell you, were another thing that were red flagged when I used to work in quality as well. And it's just so important that, we really understand again because we don't have these courses talking about the legality. You might do like a
Right,
hospital orientation where they're just like, don't get sued, here's these rights, do your e-learning.
correct.
But I think it's such a disservice to nurses working because it always comes as a surprise. It always comes as a shock
Exactly.
when a nurse's name is pulled in a chart because they pull everybody. Like what happens is like, okay, there's a case coming, anybody's name, you could have been in there on break. You're going to be pulled into court of law to say like what you did.
Correct.
And I think that we need to do so much more education in this area. And I think that it's so important that people really know what the roles of a legal nurse consultant looks like. And then two, how is it that, as nurses, as people who are practicing, how do we make sure that we remain accountable to our patients and families?
Correct.
And speaking about accountability, you often have talked about like, the system really sets people up to fail. So like I'm sure you've heard about the Swiss cheese model and all these different things. But again, on your end as a legal nurse consultant, it's a little bit of a different perspective. So in your role, how do you help attorneys and organizations see the difference between a human error by a nurse or, by someone else, or a system failure that made that harm or whatever the case may be inevitable?
Yeah, I think the biggest piece is, especially in the medical record review, we're also reviewing policies and procedures of the hospital or the hospital system. We're also reviewing the medical bylaws. So it's not just the medical record. So that's a great question. It's more so we're getting the gamut and we're also requesting documents. Like as we're
Right.
going through the record and we're also coinciding with the standard of care, we're now saying, okay, what's the hospital policy on this and pull this up. And when was the last time that policy was updated? Was it last year? And does it coincide with the clinical practice guidelines? So it's like, it's a lot of cross checking we're doing before. So usually, how I think about it when I'm giving my report it's multi-layered. It's okay on the individual side, this is what happened. Did it follow policies and procedures? Were the policies and procedures of that hospital congruent with current clinical practice guidelines? If it's not, that's an issue. So it's kind of like a lot of cross-checking, which feeds into that point that you just stated, where now this is a hospital system issue that led to this individual making this type of decision or making this type of error, if that's the case, rather than the individual
Right.
itself. So it is, and this is where you do have to have a more holistic awareness of how the systems work instead of just saying, oh, it's just the medical record. Just because it's not there, is there a reason it's not there? It's, so it's,
Oh,
and then we even go back. Sometimes I've had to look at hospital accreditation records from the past and try to see, like their reviews, like what were they dinged on? What was their corrective action? Like sometimes those things come into play as well, depending on the case.
wow.
Yeah, so it's interesting. So it just depends on the case and how nuanced I do have to go. But I know personally for me, there's a clear thing of just outright negligence versus, the whole system really setting up this person to fail. And again,
Right,
but
right.
then once I kind of give that review to the attorney, it's really up to them on how they want to litigate it, if at all. So it's unfortunately after that part, it's out of my hands, but you try to arm them with as much information as possible. And this is why a lot of malpractice cases, especially in the United States, they settle. It's very rare. I mean, we're hearing more and more going to trial. I think more and more hospitals are being a little bit more bold, in which I don't understand why, because juries are just not for people being harmed or anything like that.
Right.
Usually about 70% of cases they just go straight to settlement because they just don't want to deal with discovery and all of that, because then that's where you start digging for
Yep.
policies, procedures, things, the records of physicians or nurses, things like that. So yeah, so it can get kind of hairy quick if it's not nipped in the bud in the settlement process. But yes, to your point, I think it's always important to look at the whole picture of how that hospital system is ran and then go down the line, then go into the individual conduct.
Yeah, like I mean, again, I would probably argue in the States that it's probably even more hairy out there than it is here. Not saying that we don't have similar issues. I'm sure absolutely
Hmm.
we do. Care is care, harm is harm. But again, when you have a system that, a hospital system can be bought out by, like private equity firms, or, the insurance system where there is built in like concern about wealth and it being a profitable business where I can see all sorts of, shenanigans
Hmm.
occurring.
Exactly.
And I had this question, it just kind of came to my mind where has there ever been like a hospital policy that actually, even though that policy was in place at the hospital, that, when it was up against the law, that it didn't stand the test of time, it didn't really hold true?
Absolutely. I've seen it more often than I would like. And this is
Let
where,
them know. Let
yeah.
them
And it was
know.
interesting because when you mentioned about your role in quality, I was like, that was the first thing I thought of because I did work in quality as well. And a big piece of it was, the committees and, the policy review. And then we have to cross check against guidelines and things of that nature. So, but yes, I've seen too often more than not, either the policies and procedures just not being updated. I mean, like, where's your quality department? They're not being up, and we're not talking about every 2 to 3 years. We're talking about every 5 to 8 years.
Right.
Medicine and nursing changes almost on a daily basis, as we all know. So it was just stuff like that was completely unacceptable. Where we have 2025 guidelines, and but we're working off of like a 2020 or 2019 policy on
Hmm.
that same thing. So that stuff comes up all the time because now you can show an attorney, hey, there's a huge gap in how things should be, based on what we see here in black and white letters. I just think it's interesting. And again, I can't say it's laziness, but oh, as we all know, especially with private equities creeping in everywhere, they're just
Yep.
trimming staff. And a lot of
Yep.
times it's always the departments that are not at the bedside that are first to go. So that's going to include quality. That's going to include anything that's, there to maintain the health of the hospital. So I find it interesting that when they make these type of decisions to cut staff like that, now things like making sure that your policies and procedures are up to code gets held by the wayside. But then on the flip side, I think as a clinician as well, you should know does your policies and procedures not match what you should be doing in practice? To my point earlier, we have hospitals trimming these departments to the point where
Right.
clinicians are left out to dry when something happens because they're basing it off of policies and procedures that are in the hospital 10 years ago. That should not be. So I think hospitals can do a better job protecting their clinicians. And the first thing, just simple, update your policies to match current nursing and medicine standards. I mean, I don't know. I think it's easier said than done when you don't have the staff to do it. And that's the thing.
Well, I mean, updating them is one thing, but making sure you're following through on the practice is a
Which is
whole other
true.
thing. Like,
Yes.
I worked in quality. I'm not going to name any names or anything. I've seen it at a variety of different organizations where, all of a sudden it's crazy because like we know that accreditation cycles are like every 5 years or whatever the case may be. Right. And I know they're changing it here where they're trying to make it yearly. They don't want to let the accreditors know when they're coming to the hospital because again, shenanigans. But I've seen in certain instances at different organizations where they literally slap a date on the policy, but nothing has changed and the practice hasn't changed. And that's where it's really dangerous because you may have an updated policy, but if your practice isn't reflective of that policy, then what are we really doing?
You're absolutely right.
Are you
I
there
can
still?
hear you. Can you hear me? Yeah.
Okay. Yes, I can hear you. I was worried because I didn't hear you talking. You're like, you're absolutely right. I'm like,
no, yeah, you're absolutely right. And then that's a great point you just made too. Yeah. First of all, the slapping of the date is crazy, by the way. Like I haven't personally seen that, but I have seen where, okay, the policies are good to go. Policies and procedures are good to go, but no one's actually following through to making sure that they're actually implemented. And then there's the hurry, hurry, rush, rush. Let's make sure everything looks pristine for the accrediting bodies and things of that nature when it happens, because they're usually, given a window of when to show up. So that's not okay either. It's just like either way, I think, and I drill this in nurses, just going back to your documentation point. I see this almost every day in my work as a legal nurse consultant. I also do insurance appeals. I see the same copy and paste note in almost every chart. So if a doctor needs to be, and you probably know where I'm going with this.
Yep.
If a doctor needs to be contacted for anything clinical, an escalation or something like that, I always see in the chart, MD made aware. That's it. That's all I see. Okay, so as a legal nurse consultant, I'm looking at the chart. First of all, everyone knows in a hospital, there's like multiple doctors involved if you're admitted, right? Which doctor? When did you call them? What was the assessment? What was the discussion? What was the intervention? None of that's there. So I'm supposed to ascertain. And this patient usually is like, they have declining vital signs that are trending down slowly every hour or whatever. Nothing's there. So they're just copying and pasting. That is the most dangerous thing a nurse can do. And I wish nurses can stop. Like, stop doing that. And again, we don't need a book. We don't want a whole novel. We just need, who did you speak to? What was the time? What was the assessment plan and intervention? That's it.
Yeah, you see, I'm going to jump in there and then I'll let you, get your thought back in. I remember when I used to be in L&D, there's a way sometimes if the doctor doesn't want to come. I remember I would call and I'd say, well, I'm just letting you know, Dr. So-and-so, that the patient is having these regular D cells. It looks like this. I'm quite concerned. And I'm going to document that I've had this conversation with you and that you understand the risks that are involved with leaving the patient this way. I am on my way, Mrs. Archibald. I said, I will see you in a minute. Sometimes it's also that SBAR, right? That communication that you're having, that you're going to be documenting exactly what is occurring. And maybe you'll get the response that you want from the MD because they don't want that also to be written because they need to assess the patient. Yeah. And I do know this is another conversation where I guess after a certain number of years of practicing, you kind of get used to the fact that at the end of the day, that's my license, not the line. Like, that is my license. And I know that there still is a lot of nurses who are threatened and intimidated by physicians that they might have been yelled at, or they might have been talked harshly to, or they've been told not to call them because they're going to bed or whatever the case may be, and are very fearful of making those
Correct.
calls. And that's a whole other area that we have to address as well.
Agree. I think to your point, it's like the fear of contacting the physician when it's critically needed. Um, and just the fear of retaliation, it's a big problem. And I think, again, nurses should be taught early on about, I always say, the backbone effect. Like, you have to have that backbone to be that advocate for your patient. It's just you have to. And I think nursing's not for you. I don't think healthcare is for you if you can't simply advocate. And that means, to your point, calling that physician and telling them this is what's happening with your patient and being like, okay, I'm going to escalate this. Like, I think people are just so afraid of losing their jobs. It's such a tight economy, especially now. And I just think you're just doing a disservice to the patient. You're doing a disservice to yourself and your license as well.
Yep.
And again, I learned this early on in the operating room when a surgeon tried to throw a needle across the operating room and it almost hit me. And I said, "What the hell are you doing? Are you nuts?" Like, the Brooklyn came out of me. And so, like that's where I found my strength and my backbone to basically say, doctors are human. They're people just like we are.
Yep.
Just have a respectful dialogue with them, and that's it. We don't have to be buddy buddy. We don't have to be friends. But at the end of the day, that's a patient. That you're responsible for that patient. And I think we got to drill that, especially in our baby nurses. We're not here to make friends. We're not here to dilly-dally. If you see a trend of vital signs going not the way it's supposed to, you need to get on the phone immediately. Like, you don't wait
Yep.
till the pulse ox is in the 80s. Like, we don't do that. So I just think a lot of this stuff can be so prevented just if we opened our mouths. I mean, point blank, period. Point blank, period.
Can we just, yeah, can't we just teach? See, it's like the advocacy of the patient is huge, right? Because at the end of the day, like, what are we doing if we're not trying to ensure that our patient is at the center of the work that we're
Correct.
doing? But then also that self-advocacy piece. I worked in the OR, and yeah, I've seen physicians throwing like surgical instruments up because they're, for whatever reason, they're frustrated about God knows what. And that's not
It's not
acceptable. Like, that doctor throwing that, yes, the Brooklyn should have came out of you because that's not
right.
right. And again, at the end of the day, that respect should be mutual. At the end of the day, you're a colleague. You have your knowledge, skill, and judgment. You have the area that you're practicing in, and you're still a human
Correct.
being.
Exactly.
Respect should be given as
Always.
well. That's my little rant there. Hot topic in 2026 is, what is it? You know it is. It's AI. AI and decision
Yes.
making. And again, we keep on hearing all of these various different stories and cases in which AI had documented something, the other person did something else, and then who's responsible? Who's responsible, Cambria?
Honestly, the clinician's responsible. At the sole end of the day, the clinician is the one with the license, not the AI. And I think, again, unfortunately, AI is not going anywhere. So we have to really
Yep.
hone in on that piece. But I think people start to become lazy when it comes to AI. AI is only as effective and intelligent as you make it to be. So
Right.
if you
Right.
don't have the critical thinking skills or the competency or the acumen to understand what's going on, the AI is not going to know either. So it's kind of like the blind leading the blind a little bit. So I really truly believe that it's going to be interesting, I think, for my field, seeing this come up in court. I have not seen this yet, and I'm sure, give it a year or so, especially now, right? Especially now that it's like integrated in the EMRs and, it's in the chat bots of just basic triage and things of that nature. I'm sure we're going to start seeing plenty of court cases about this. But I just think, as a clinician, if you are forced to use it in your healthcare system, you have to slow down and double check what's going on. And I think
Yes.
that's where people are missing the boat. They're just solely putting blind faith into it. And that's just not how you should do anything. If you know you didn't write it or you didn't document it yourself in that manner, you need to double check your work. And unfortunately, to me, that's creating more work for the clinician. It's not making things easier. And that's just my personal opinion. I'm sure there are going to be other sides to it, like, oh my God, It's making my transcription much easier, but your transcription got a whole bunch of medical errors in it or grammatical errors. So
Right.
it's like, is it truly helping? Like, I just don't understand. So I think it has its purpose in place. I think it's more so who's making these decisions at the head of where it's applicable. And I'm sure, again, the stakeholders that should be in those conversations are not there. And that's the problem I'm having with it. Who's designing these AI products? Who's implementing them into these systems and making sure who's doing the quality checks on them? That's the questions we need to have happen, which I'm sure are not happening. So yeah, it's going to be interesting in another year or so for sure. I'm sure of it. Yeah.
Yeah, I'm sure that's another place that nurses are needed. We definitely need to step our foot into that
Yeah.
area because I think that again, it's that whole saying like if you're not at the table, you're on the menu. And again, I think this is where we have to put on those various different hats. Again, you're right. It should be used as a tool, as an adjunct,
Mhm.
right? I remember before we had AI filling in the gaps, there used to be God, control Z or whatever, where, for example, you're just literally copying, pasting previous entries into the chart. And that was a
Yeah.
problem. So again, we just need to do the right
Exactly.
thing, right? And again, I know, and here's the other side of that conversation is like doing the right thing is getting harder because nurses are working with
Yeah.
less, right? Less equipment, less time, heavier, more chronic ill patients, maybe short staffing, not having rest. Like the system is making it even more difficult for us to do the right thing. And we have to recognize that too. So I always want to put that in as it's not even a caveat. It's a fact that like, let's look at the root causes to why some of these things are happening and start fixing the root cause because I don't think we're
No,
there yet. I don't think we're
we're not
even
close.
close. And
Yeah.
and on the topic of, equity and looking at, AI and knowing that there's going to be errors and gaps, I really do want to touch on talking about like marginalized communities, I should say, communities made
Mhm.
marginalized, and the whole idea behind health equity within some of the work that you do. So, in some of the work that you do, you focus heavily on how healthcare systems and failures disproportionately harm marginalized communities. What are some of the invisible legal risks that nurses working in these communities should be aware of, and how can they better protect both their patients and their license?
Yeah, I think the problem we're having, and it's to this day, nursing education and medical education does not. I mean, there's fights to this day on whether explicit language when it comes to disparities should be educated on and why things are the way they are. And so I think, first of all, as far as nursing education, there's a huge gap, and it's still a gap. And we're not
Yeah.
addressing the gap of that type of education. And as a result, nurses, I mean, you only know what you know. And I think to behoove a nurse to know whether there's an actual disparity, especially when it comes to, example, Black maternal health, since this is Black Maternal Health Week in the United States, to not educate yourself in what that looks like is to me a disservice to everyone, including yourself. And I think nurses have to continue that education on their own. It's not going to come from some grandeur, forum as it should. It's really, as a nurse, are you arming yourself on how to take care of a Black mother? Are you equipped to take care of a Native American mom? And those nuances in between. And even if you don't know 100% of the time, are you willing to ask the questions? Are you willing to
Right.
ask those hard questions to inform yourself? I think what I see a lot, especially with healthcare disparities, we have a lot of cleaning house to do when it comes to our own nurses. We have so
Yep.
many people in healthcare that do not belong there. They have biases that they will not get rid of while they're taking care of patients. They're very vocal about it. They're very adamant about it. And healthcare systems are just allowing them to continue to work with those biases. And that's not right. It's not okay. And I think, like I said, that's just a whole cleanup messaging all in itself. Like that boils my spirit that there's nurses like in my comments agreeing with racism and they're agreeing with how certain populations should be treated. So again, as a nurse, just that in itself, if you have a trend of taking care of a certain type of group and class of persons a certain way, which is different than how you would treat other patients, and that's documented somewhere or that can be proven legally, then you're putting yourself in the middle of a discrimination suit. So it's just, there's so many ways you can kind of go about this, but I just think nurses as a whole should arm themselves with the education that yes, different populations have different needs and they have different disparities for a reason. And to your point before, what's the root cause of most of those reasons? What is it? And if once you understand that, then you can actually open your eyes and take care of these patients as a whole being. So that's my spiel on that. I can go on for a lot. That like boils my spirit that patients are not treated as human beings. Like, I'm not okay with that ever. But we do have people in the
Yeah.
healthcare field that shouldn't be there. So,
Yeah, no, I completely agree with you. I think I would say that's probably the most deadly type of healthcare provider, a healthcare provider that does not see another individual because of whether it's the color of their skin, the tone of their accent, the way that they might have not been born in America or born in Canada, that they're going to treat them as less or dehumanize them or give them substandard care. I think that those nurses, those physicians, whatever role they are in healthcare are some of the most deadly and damaging individuals. And I completely agree that they should never and have no place to work in healthcare whatsoever. And I think this is where we should have a calling in, right? I think that, we have the ability for internal reporting systems. And if this is the whole, like, if you see something, say
yes,
something. I think that we as nurses, like, we should be protecting our patients and families. And if you are seeing that, a particular nurse treats a patient or, different patients in certain ways, or you've caught that offhand joke in the nursing room, I think it's time that we report these
this time.
people. Report them online too. They're up because a lot of these people think they're anonymous. They think they're smart. They think they're safe. No one's safe or should be safe from racism. If you're going to be racist, get expected to be called out because everyone wants to talk about freedom of speech. There is freedom of speech, but there's not freedom of
That's correct.
repercussion. And at the end of the day, if that's going to harm somebody and the profession that you worked in where you decided to take care of everybody and that's not a part of your line item, then you don't deserve to have that license. So I am with you 100%. I'm ready to rip licenses from nurses who are racist. It is all good.
Absolutely.
One last thing before we go, I want to talk about some of the work you're doing. CJN
Yes.
Network, does that sound
Is that
familiar? So you've either recently launched or has it been launched
yes,
now?
we've launched
Okay.
we've launched CJN Network. So this is my own media network that I've launched February 2nd. Yeah, so CJN Network is my baby. It's my own media network that we launched back on February 2nd. We're in the almost going on 3 months now. So it's a fully fleshed out media platform of blogs, video episodes, and I really wanted a forum, first of all, that wasn't owned by Meta, Google, TikTok, because I've been in situations where those media platforms, yeah, they went dark. And as a result of that, all the media was gone. And even though we
Mm.
always save our own media, that's disastrous. So I said, no, no, no. I need my own that where I don't have to be censored. I can say what I want to say. I can educate the way I want to. So it's a platform of more longer form videos. And right now I'm doing a series on patient advocacy, things to look out for. I think my goal is also for patients to understand why healthcare is the way it is. And they can
Mhm.
do to better inform themselves and not blame the nurse or the doctor all the time when some
Right.
systems issue. So yeah, so I'm super excited about it. It's a lot of work, as you are very well aware of maintaining your own platform on top of social media and things of that nature. But I'm very proud of it, and we'll see how it goes. I'm gonna commit to it. I already have subscribers that are committed to it, so I'm excited of where it's gonna go. But that's my baby.
I'm excited too. Like I saw your network and I'm like, good, we need more of these types of things happening. So I can't wait to continue to see what will happen in the future with the network. Where can people find you, Cambria?
Yes. So outside of CJN Network, which is cjnnetwork.com, I am on social media. My handle is at CJN Legal Nurse. So I'm on TikTok, Instagram, Facebook, YouTube, as well as LinkedIn as well. So, and if anyone knows me, I'm mostly on every day. as we all know, it's just something always happening in the healthcare world, almost on
Yep.
a daily basis. So it's sometimes hard to keep up if you don't do it every day. So I try to post at least once a day. And then I also have, in my profiles, if anyone needs advice or mentorship, I prefer that you email me directly. If you can imagine, I get a lot of DMs. I just can't get through them
I'm
all.
sure.
But if you email me, I will read it. I will make sure I can get back to you and try to help as much as possible. So
My goodness, that's so kind of you. Well, thank you so much, Cambria, for
thanks.
coming on the Gritty Nurse podcast. Such a fruitful discussion. I'm sure we're probably going to have another conversation. We have to. At some point in time when the world isn't burning down in the US, I might make an appearance.
Yes.
But again, yes, thank you so much for coming on, sharing your knowledge about being a legal nurse consultant. I'm sure there's so much that our nurses can take away from this conversation. And good luck with your CGN network. I expect that there'll be some great things that are coming. Before we go, anything that we missed that you want to touch on?
No, I think we've touched on quite a bit. So I just want the listeners to just continue to be empowered to speak up when something wrong is going on. Just speak up. I just think people are getting too funneled in and just hollowing in because there's always this notion of nothing's going to happen. This is how it
Yes.
always is. And I think we're just doing a disservice to ourselves. So if anything, if you see something, say something. It could save a life. It could save someone's health, career, whatever the case may be. And you just never know. So I just think we need to be better advocates for each other.
I love it. I completely agree with you. So with that, thank you so much for coming on.
you.
And take care.
care.
Looking for a great gift for a nurse or someone who needs to learn about nursing? Check out my national best-selling book, The Wisdom of Nurses, Stories of Grit from the Bedside. Thank you so much for listening to The Gritty Nurse with Amie Archibald-Varley. If you're watching on YouTube or listening on Apple Podcasts, Spotify, iHeartRadio, or any other podcast platform, please hit the subscribe button so you'll never miss out on any awesome episodes from The Gritty Nurse. Thank you so much and stay tuned until next time. Stay gritty.